Well, hello and welcome again to the Emerald Coast Medical Association podcast, Medical Mastery. Thank you for being here again. And we have a brand new member and new guest and new in town. It's Dr. Kenny Chantasi. Is that correct?
Yes.
Did I say it right? Okay, good. And Dr. Chantasi is here, new member of the Emerald Coast Medical Association. Thank you for being here as our guest. And we're going to learn a lot about you today and converse a lot about your thoughts, hopefully.
Sure.
So, well, let's start off. Where are you from originally?
Originally from New York City.
I've heard of it. Yeah.
Born and raised in there, and then grew up in North Jersey.
Okay.
High school and college over in Jersey. Went to medical school over in Long Island at New York College of Osteopathic Medicine.
Okay.
Did my internship at Nassau University Medical Center.
Gotcha.
Was tracked categorical to PM&R.
Yes.
Actually, it was interesting. I was originally medicine categorical.
Yes. So was I. Yeah.
And then I was working with a cardiologist. I wanted to do interventional cards, and he's like, "You look like a family guy. I don't really have a good family life."
Yes.
He's like, "You see those guys coming in a little later and leaving a little earlier and dressing a lot nicer than us? You might want to hang out with them."
You know, that's actually some really good advice, which is that, you could do whatever it is you're going to do, and you could do it for free, and you could do it all out 22 hours out of the day. You're going to burn out. So the whole idea of our career is to kind of create a long-term vision of how we can impact the most amount of lives that we can. So some sage advice that you got relatively early. Now I'm going to take you a step back here and go back to your undergrad days. What'd you study?
Biochemistry.
Biochemistry. Same thing here. I did biochemistry and math. So good on you. Now, did you know at that time, did you just like biochemistry, or was it something that you thought was going to propel you towards medical school?
Something I thought would be useful and help me in medical school.
Yeah, one of the things that I thought about my undergraduate career was that, and this was just naive, is how surprisingly complex biochemistry is.
Absolutely.
It's extraordinarily complex, and you can get, we kind of have a tendency to think, you have this input into our body and this output that comes out. A medication comes in, it does its thing and comes out. And I use this all the time to kind of warn my patients when they say things like, well, how does this medication work? And I say, this is extraordinarily complex. It's very, very difficult to explain in words how these things actually work. We have models for all these different things, but this certainly got me into the line of thinking kind of on a functional basis about a lot of things, and kind of it should start to make some sense, even though it's kind of extremely complex.
I would agree.
Yeah, and so you went from there to medical school. Now in medical school, were there any particular interests that you liked? Did you like it all? Did you find any rotations that were better than the others?
People always ask, what did you want to do when you grow up? I always just wanted to be a good doctor.
Yeah.
Didn't really care what I was doing. So it didn't really dawn on me what I was doing and where I was going, just do good whatever I was doing.
Yeah.
And so that's why I did medicine categorical. I figured cardiology seems like a good field.
It's not, I'm just kidding. But being in cardiology, that's why I said yeah. So you could have done a lot of different things, and you ended up going to perhaps a lesser known specialty. Can you talk a little bit about PM&R and kind of where that fits into our realm? Because that's
Sure.
It's an interesting one.
Yeah, PM&R, it was crafted out of World War II, actually, where patients were survivals of war, tragedy, amputees, and prosthetics were important to recover and regain function and return back to the community. So that's really where it started.
And it's what does it stand for? Just for
Physical Medicine and Rehabilitation.
Yeah. So it really works on the aftermath of some sort of acute injury, how we're going to get the most functionality out of these patients as possible. And I would assume that there's any and every modality available to you that you could possibly use, whether that be interventions, procedures, medications, physical therapy.
Physical modalities, technology.
Yeah. And I would imagine that's changed even over your relatively short career so far.
Absolutely.
Yeah.
I graduated in 2010, and we were doing baclofen pumps and Botox, and baclofen pumps are still the same, but what's new is exoskeletons and artificial intelligence and integrating AI with exoskeletons, trying to determine the next vector or next movement and how every step will be calculated.
Yes, because walking is an extraordinarily complex motion that we actually do there, and we don't really realize all the things that our muscles are doing along the way, and to kind of think of how do we recapitulate that in some sort of motion that's
correct it immediately.
Yes. And one of the things that we have, there's a lot of problems that come with us as we age. Cardiovascular disease, cancers, those are different animals in a lot of different ways. But one of them is sarcopenia, musculoskeletal wasting, falling. And I found that, that falling and breaking a hip issue has a lot to do with patients being able to catch themselves and be able to kind of quick motion. And
they have all these new gadgets and inventions. I was just looking at something where elderly person can wear a vest. And basically, as soon as it senses that you're falling, it explodes and deploys airbags, even covering your head and hip.
Oh man, that is fascinating.
Right?
Oh man, sign me up for that. Okay.
Then talking about sarcopenia and joints and everything, Kickstarter has a modular exoskeleton that you can apply to your hips and your knees. So the hips are for climbing, doing dynamic range and like hiking, and then the knees component is to save your joints and brace yourself. You can run up to 7 kilometers an hour without breaking a sweat.
Wow. I mean, it's fascinating that
right?
technology is coming along here. Now, how much of that when you are practicing, I mean, theoretically, we would want the person to be able to do as much as they possibly can and then use these extras as just extraneous efforts as we could. I don't know, it seems like it's almost like we're getting into the Dune world where you just have these machines that can do all of that for you, but that's not really the goal of PM&R, right? It's to kind of have you be functional as best as possible.
I would say the primary goal is quality of life.
Yes.
And so whatever way that is.
Yes. And that there's a lot of verisimilitude with what we say here about these things. My goal is, cardiology is my foot in the door for you, but ultimately I want to kind of increase the meaning in your life and how we can kind of get you to where you feel better, and then you can go do those things. But I could think of very little than a patient who can't really move all that well to all of a sudden gain that mobility. That must be fascinating and wonderful for them.
I really enjoy seeing that and gaining their independence and mobility. Just they can't walk around, and then for example, they can't walk around, but they need something for the community, and we can get them a power chair for the community.
Yeah.
Or they can move around within the home, but it takes them a very long time. So they might need a power chair within the home just to be able to maneuver to do things in a timely fashion.
Yeah, so you're giving them independence. And boy, people do not want to be a burden on anyone. Absolutely. That is something that really, really weighs heavily on us as humans. And so that's great that you're able to do that. Now, one of the things that kind of overlaps in your world is going to be pain management. Is that right?
Correct.
Now, how do you view pain? How you were trained in this? Is that right?
Correct.
Okay.
So, pain is subjective to the patient, but my role is to try to improve the pain for you to be able to do the therapy, improve with your function, and not be a barrier or have pain or anything be a barrier to your progression in therapy.
Yeah. And, pain is wonderful. It kept us alive, our ancestors alive, when we realized that, there's this thing that is telling us something is not working right. And so that's a very helpful signal to us. But chronic pain is a different animal. This is something, we already know that there's something wrong. We don't need to get constant reminders of this kind of thing. So how we can kind of blunt that response so it can allow us to empower ourselves to get stronger and better. Now, are you using, what kind of modalities are you using for management of pain in your patients?
Well, in the hospital setting right now, I'm limited to medications, some trigger point injections.
Yes.
Corticosteroid use is limited because patients are ill, critically ill, and sometimes they just had surgery, contraindication, other infections. So kind of limited, but pain medication and modalities, whether it's massage, therapy, modalities with heat, electrical stim.
Really, whatever you can get your hands on that's going to make pain better for
Correct.
them. Now, have you ever veered into perhaps some of the more esoteric side of things, hypnosis, acupuncture, any of these other things that are perhaps a little bit more in the extremes or periphery of our kind of profession?
Well, I'm a DO, so
Great.
I also am trained in manual medicine
Great.
and osteopathic manipulation techniques. So I believe that helps. There's a role for it. I think acupuncture, our board question has taught us that traditional Chinese acupuncture has been shown to be effective for chronic pain management.
That's a very excellent diplomatic answer there for those kind of things. Yeah. And this might be a good time because our audience here is certainly members of our community, members of the Emerald Coast Medical Association, but also patients. And so maybe we could have a little discussion about the difference between allopathic and osteopathic medicine. When it comes to our big family, there's very little difference at all, where we're talking about slips of paper that are in between, but maybe just a little bit of contrasting elements between those two. You want to go ahead?
I mean, I think the roots of osteopathy are based from the 20s when Andrew Still, the founder, was an MD also,
yes,
and felt that some of the medications at the time were more caustic and dangerous than natural healing.
Yes.
And so he worked and found some manual techniques that would help drain lymph and fluids and mobilize tissue rather than toxic substances, and developed osteopathy with that.
Yeah, and the allopathic field took a little bit more of a, here's a problem, we're going to fix it with some sort of medication or some sort of intervention. If you have a broken bone of some type, well, we're going to fix that fracture in some way. If you have a diseased appendix, we're going to remove that, and that's taken care of. If you've got strep throat, we're going to give you antibiotics for that. And it's an effective strategy in a lot of different ways, but it doesn't necessarily take into account the holistic picture. And I think that's kind of it's oversimplified certainly, but maybe a somewhat fair comparison between those two is that the osteopathic side tends to say, like, are there other things that we can do besides just straight up intervention on these ailments that could get, again, better results over in the long term? I think actually those lines, those Venn diagrams are overlapping a lot more nowadays. But so for all intents and purposes, we treat DOs and MDs the exact same in our field. And I think patients probably should as well. Is that your experience on that?
I would say the evolution of medicine kind of embraced mind, body, spirit.
Yes. Yes.
And so that's really the essence, I think, of osteopathy too. And I think people have embraced that.
Yeah. Oftentimes in my clinic, the very first question and the most important is, how do you feel? I will say, I'm not here to treat numbers. I'm here to treat patients. I don't care if your heart rate's in the 40s. How do you feel? If you feel great, then well, what am I doing here? Okay, so yeah, I think those kind of they're kind of focusing in together, I think, as we try and treat our patients at large here. So you went through PM&R. Now tell me about your career right after that. What did you do?
I graduated and then I went to Columbia University Medical Center. I was there for about almost 10 years.
Yes.
Just inpatient, outpatient consults, general PM&R.
Is this academic side too? Yeah. So that something that the lay public may not get quite as much an appreciation for is academic healthcare is different than being in practice or being in your current job, which we'll talk about in just a little bit here. But it's a totally different environment. Yes, you have the same patient care issues in a lot of different ways. You are expected to kind of participate in research and promulgate the idea of certain things like that. Was that your experience?
Yes. Research is definitely part of a recommendation.
Highly recommended, yes.
Yes, highly recommended if you'd like to continue.
If you appreciate the paychecks that you're receiving. So, did you like the academic world?
I did. I mean, it was nice, but it's also not as financially rewarding.
It isn't. That is true.
But the volume is also very different as far as academic, because it's geared towards training and education. So the patient census and volume load is very different from private practice.
The volume is different. Also, when you are training others, you really realize pretty quickly how little you know about certain things. And you really have to crystallize a lot of the ways that, teaching something is going to expose some weaknesses in your own thought processes pretty quickly. I wonder if that is something that you had experienced as well.
Absolutely. I would say that the first year in practice is the first year, the year I read the most.
Yes.
Because I didn't know a lot.
I did not know that. Yes, exactly. And I remember being a third-year medical student and on the critical care rotation, and my pulmonary critical care attending saying, the very first time you see the medical student turn their head to the intern, turns their head to the resident, who turns their head to you, and you have to make the decision, that's a very interesting time. And so indeed, that was interesting, but formative to all of our careers. So
one of the other things that I do also is I'm an osteopathy board examiner for my specialty.
Oh, excellent.
So I'm an oral board examiner and test question writer.
Man, okay, so a lot to cover there, because The oral boards are a totally different animal to try and get your head around. That is a very difficult experience. I'm very fortunate that we didn't have the oral boards, but my wife in radiology did have oral boards, and she was a way smarter internal medicine doctor when she was studying for her oral boards in radiology than I ever was an internal medicine doctor. So explain what that process is like.
So to become an oral board examiner, as soon as I finished and graduated medical residency, I reached out to the board to try to become an examiner or just kind of like a proctor or monitor to get my foot in the door to kind of continue education like that.
Yeah, good on you.
It was kind of recommended by my program director and it was a great idea.
That must have meant that you had some general affinity towards teaching and kind of felt that you could impart this wisdom onto our younger practitioners. So good on you for doing that. And you're also doing board questions as well.
Right.
You know, that's something that kind of, as you get into the field further along, you start to find yourself into that realm where the board services find you and say, hey, would you submit a question? That request becomes a little bit more urgent over time and saying, no, submit a question here if you would. So are you still doing that right now? Okay, so there's still a part of you that keeps your foot in education.
Yeah, I just got a request for doing oral boards in April and I volunteered.
Lucky you. No, seriously, good on you. That's great to do and great for giving back and making sure that we're kind of building this healthcare community for generations. Now, so you spent 10 years at Columbia, then where did you go?
I went to Fargo, North Dakota.
As we all do. We've all been to Fargo, right? So Fargo, North Dakota seems far afield from New York City.
I spent 5 years there.
Okay.
We talked about how academic medicine doesn't really pay.
It's true.
And I got married.
Yes.
Had a child, looking for other opportunities. Hard to live in New York City with a wife and kid and on an academic salary.
Yes. I don't understand how anybody lives in New York City, to be honest. I mean, going to school there is it's just a crazy place, but either way.
I think they live in debt.
Yeah, that's probably it. Yeah, I think that's the way that it goes. So you moved to Fargo. Now that is a sea change from New York City, Fargo, North Dakota. Tell me what that was like.
Culture change for sure, but it was nice. I mean, I was medical director for the inpatient rehab unit over there.
Yeah.
Then became department chair. Kind of helped expanding and growing for the department.
It's a new responsibility for you too, to kind of go to the department chair. That's pretty young to have that kind of responsibility. So what was that like?
Just felt like a natural progression.
Good. Yeah. One of the things that happens is sometimes, you may get a title. Sometimes that comes with increased remuneration, but it also comes with quite a bit more work and different work than what you're doing on a day-to-day basis. So you had to bide your time a little bit differently, I guess, as the department chair, even from what you were doing before in academia.
A little different, just more administrative and reviewing and overseeing other areas.
Yeah. Now, it's often said that physicians are the most difficult to work with. Did you find that experience?
Not so much. I guess I'm fortunate to find people that are good to work with.
Yeah. Okay. So tell me where you went from there.
From there, I had an agreement with them for about 4 years or so, finished the agreement, was looking around. My wife was asking if we could go someplace warm. Okay. And happy wife, happy life.
Indeed. That's true.
So just started looking around and I saw an email from Encompass at Panama City and reached out, and that was in December, and I was here in June.
In June. So this is just this past June. Correct. So this is just a few months ago that you come down here. And now what is your title over at Encompass?
I'm medical director.
Medical director over at Encompass Hospital. Well, Encompass is a sponsor here for the Emerald Coast Medical Association. So there's some great overlap here. You're a new member of the Emerald Coast Medical Association. This is really just great for all of us here. And they do wonderful work there. So even though you're kind of relatively new in terms of the Encompass facilities, tell us what Encompass does, because not everybody in our community knows.
So Encompass is an acute rehab hospital. There are different hospitals, as we're aware. There's acute care, where patients are ill and they get stabilized. And then there are other other facilities that are available, including skilled nursing facilities, long-term acute care, acute rehab, swing beds, There are a number of them. Acute care is just one role for post-discharge,
Yes.
post-acute care. And we look at patients that are able to tolerate 3 hours of therapy a day
Okay.
and would benefit from at least 2, if not 3 modalities, meaning
Yes.
PT, OT, and speech.
Okay. So these are not necessarily decrepit patients that aren't going to be able to move at all. They have to be able to participate
Correct.
in some way. And so, in other words, this is some sort of meaningful bridge to a different kind of more prolonged life for them and more enhanced activity. Is that right?
Right. I think patients that are acutely ill, if they're able to move aggressively and high intensity mobilization, they can recover and mobilize their fluid, improve their muscle mass. As someone stays in the hospital, for each day that they remain in bed and not moving, they lose 1% muscle mass, up to 50% compound.
Oh, man. Yeah, and that's extraordinarily difficult to get that muscle mass back. It's not the same as just one day and you get that back. No,
Right.
It takes a long time of nutrition and exercise in order to get that back.
And as we're older, we lose it quicker and it's
Yes.
harder to regain. So it's even more difficult for this population.
Yeah, and because you are an expert on this, and maybe you could talk. It's something that we talk about with our patients all the time about just how critically important muscle is and building that and utilizing that.
I mean, muscles are very important. I describe our body as the bones are the scaffolding and the muscles are the structures around it. Sometimes we can have weak scaffolding, but if the muscles are super strong, they can hold the bones in place.
Yes, and again, maintaining that muscle mass is almost equal to your ability to move in the future. It's not quite that. There is still some proprioception that comes along the way, but maintaining that muscle mass, building muscle if we can, but maintaining that muscle mass is absolutely crucial. And, a lot of patients tend to think about weight, just how much they weigh. You can lose the muscle mass and then get back to the same weight with just a lot of fat stores.
Absolutely.
Not the same
Not the goal.
composition. No, not the goal at all. And our rule of thumb is every day in the hospital is 3 days until you feel better, but yours talking about the muscle mass is a lot better.
1% compounded every day.
That's a lot. So now, what do you think are, do you focus on all the muscle groups together? Are there certain ones that you say are probably prime movers because they encompass all the others whenever we utilize them?
I feel like hip flexors and proximal muscles are first and easy to go. And so we try to work on those. Patients want to focus on walking. I want to focus on sit to stand and transfers.
Yes.
Because you can't get up and walk if you can't stand up straight.
Yes. Now, when are you deciding whether to do, are you always going to do unilateral movements, or are you going to focus, if they just have no strength at all, on doing it bilaterally?
It's typically bilateral.
Okay.
I mean, we don't want one side to overcompensate and become weaker, so typically bilateral.
Awesome. And then, the Encompass facilities is not just doing these kind of strength exercises, it's also OTs. Maybe you could talk to us a little bit about what OT is and why it's so important to us, because it is not PT.
Correct. So PT, I'll describe as gross motor movement and large muscle groups. OT is fine motor groups, fine motor, small muscles. Typically, you think upper extremities.
Yes.
So a lot of people think OT, upper extremities, but it's really fine motor.
Yeah.
And OT is gross motor, so lower extremities.
So it's the difference between getting out of the bathtub versus feeding yourself.
Correct.
Those are different kind of things. And one of the things that I've been impressed with in seeing and knowing some OTs over time is things that we don't really think about, like how do you put on your socks? And other things that we kind of take for granted until you're injured and you're not able to do those motions. How would you go about doing that?
I mean, I think OTs are very creative.
They have to be, yes, yeah.
And like we were talking earlier, we do things sometimes to any means to try to help the patient recover. So,
Yeah.
for
Whatever
example,
resources we have. Yeah.
for example, a patient is unable. They had a stroke. They have a peg and they need to feed themselves, but they can't hold the bag or the can. So I've had OTs develop hanging apparatuses for them to use so they can feed themselves with one hand.
That is something that we never think about on those kind of things. So we have to have it because, I mean, to us, we say things like, well, you need to make sure you get a certain amount of protein per day. And we don't think about like how they're actually feeding themselves, much less procuring food and all the other things that go about that. Speaking of which, do you talk to your patients? Is diet included in all of this rehab?
I try to. I
Yeah.
think it depends on the patient's capacity at the time,
Yes.
but I try to include it.
Yeah. The worst prognostic indicator for patients, as far as we've seen, is poor insight into their own care. That's going to be the worst thing that can ever happen to you. So those that can understand it, certainly taking that time usually pays dividends for them. Now, there's also an element of speech therapy. Is that right?
Correct.
So maybe you could talk a little bit, because that's not necessarily just talking, is it?
No, it's cognition, speech. It's actually speech-language pathology. So they'll deal with all types of brain injuries, aphasia, speech, cognition, memory.
Yes. And the other thing that kind of falls into that whole group, swallowing issues, which
Absolutely.
ends up, that's the bane of the existence of a lot of our older patients that we end up suffering from. And I mean, if they're aspirating every time, you're going to have a lot worse things to worry about than their heart or anything else. That's going to take care of them pretty quickly. So
Along those lines, though, Encompass, the speech pathologists are FEAST certified now. So they're able to do flexible endoscopic esophageal scopes.
great. Okay. So we can diagnose other pathology that's going on there, get the correct intervention. Is that fair to say?
And see where their dysphagia is really occurring.
Yeah. So swallowing mechanism is another thing extraordinarily complex
Right.
until it doesn't go right. And then so trying to fix that, those people who use a lot of brain power that I don't have whenever those kind of things come up. So very thankful to have them all around. So you've been there about 4 months. How has your experience been over at Encompass?
I really enjoy it.
Yeah.
I think people work well. It feels like a little family, and it's collegial. I enjoy it.
Yes, Tony Bennett, the CEO, is an excellent guy. Really like him very much. He's been a stalwart donator here of his time and his efforts and support of the Emerald Coast Medical Association. So we certainly appreciate that. And glad you're here in town. Glad you're enjoying working over there. So let's talk a little bit about what do you think the biggest barrier, the biggest hardship that you have to go through in PM&R right now is?
Insurance. I think it's sometimes insurances may not want to approve a patient to come to rehab.
Right.
And so they'll say the patient is too good or does not need that intensity. And so we'll do appeals to try to argue and go to bat for the patient.
Yes.
But sometimes insurance companies have their guidelines.
And it's hard to argue that this kind of intense, because you guys are going to push patients more than they would push themselves at home. I'm sure there's data to support that y'all will push patients a lot more than they will do it at home. So in other words, their rehabilitation, their own independence will be better.
Absolutely.
So it's sad when you have clinicians that are saying, hey, I think my patient would really benefit from this kind of intervention, and insurance says, no, that's not the way that they would think about it.
We have, our program is 3 hours a day, 5 days a week, 15 hours of therapy a week. But there are modifications we can do to adjust for patients if they're not able to tolerate that intensity. So we work with patients as much as we can,
Of course,
to try to accommodate.
Yeah, again, we ultimately want them being as independent as possible, and that may be limited in somewhat, but even a little bit more independence is better than none.
Absolutely.
There's an analogy here with nephrologists that say, even if you make a little bit of urine, that's better than zero urine whatsoever. How about, you had alluded to earlier a little bit of some of the technologies that are coming online that are helping our rehab potential inpatients. Tell me about some more. What does the future look like, say 10 to 15 years from now, in terms of PM&R?
It might be a little scary.
Yeah.
I mean, we have data analysis and models, and everything I think these days is looking at data analysis, collection, and analyzing the data. We will take patients. I think what we're going to do is we're going to take patients, we're going to score how they're doing based on whatever metrics we have, compare it to their progress, and determine based on this risk stratification or these comorbidities, this age, this whatever, will determine that they should have this much functional gain. If they don't meet this metric, what is wrong?
Right. Is our screening off? Did we not diagnose them appropriately? Should we do some other sort of intervention or something along
Is our
those
therapy not intense enough?
Right.
Did we do?
Right. Can we push them and get more? Oh man, that's going to be really good for us overall, and especially to be able to do it quickly, I think is a good idea. How about pain? What do you think is going to be the future of pain 10 to 15 years?
I think pain swings back and forth with ideology of pain-free and quality of life.
Yes.
Right now, people are on the more conservative swing, I think, and being judicious about pain medication, and I think it's appropriate. But there are some patients that suffer with that.
Yeah, so I think this has been fascinating over the past couple of decades because, we went with pain is the fifth vital sign.
Absolutely.
And that wasn't necessarily the best thing that has ever been to our patients because, it started this argument of should we ever have any pain? And it went so far, and we had, frankly, a lot of deaths because of our management towards that end of trying to alleviate that pain. And now I do believe the pendulum is swinging, or at least it may have swung to where we're taking a much more conservative approach. Now, there are other interventions, things like medical marijuana that provide some benefit to a lot of patients. So I think your insight is keen there to say that the politics might be infusing this in the future more so than our technology.
I think part of it is also pain management is really more pain acceptance and understanding where you are with pain and working with it rather than trying to alleviate all of it. Just kind of working with where we are, quality of life. Are you able to do your activities of daily living? Can we improve anything about your quality of life?
Yes.
And do we need to optimize your medications, or do we have to decrease them so we can do something else, or do we have to add more physical therapy, adjust your diet?
Yeah, so you can get more meaning in your life.
Absolutely.
And you can do more functionality. I think sometimes when you talk, certainly in the lay public, about things like how opioids really work, and that it's surprising. I mean, they're pain relievers, but they don't really eliminate pain, so to speak. They make it to where you just don't care about the pain. And I think that says a lot about pain in general, which is that the untoward stimulus is the suffering that we have from it. It's not necessarily the pain in and of itself. It's the fact that it weighs on us so heavily. And opioids can take away that and your care for a lot of other things too.
That's when it becomes problematic, is I think when you stop or you're coincidentally treating physical pain, but then you're also treating your emotional pain.
Yes, it's well said. And because pain is subjective, it's very difficult to find where that line really is, because you don't want anybody to suffer. I don't want anybody to have pain ever. I mean, that's not a thing that I want, but we also want to do the maximum amount of good we can. And we know that if we over-treat this, we can get into some bad places. Right. We had talked a little bit about it before, but tell me how AI is going to integrate into your field.
I mean, already it's kind of integrated in the sense of making sure that we have all the diagnoses that we can at the end of the note.
Yes. For billing purposes, yes.
Correct.
That's right, yeah. I mean, we have ours to where I'll record our conversations, then AI will generate a note from that. And it's there's some good fidelity there. It's not great. One example is that I often will say to my patients that certainly I'm making assumptions in some ways, that I'm assuming you're not doing a lot of cocaine or methamphetamine. Now, they will typically respond jokingly that, just a little bit. So my note will say, patient admits to a little bit of cocaine or methamphetamine. So you do have to read over these notes. But either way, it's not necessarily getting all the subtleties. But I think that is getting better. So I think notation-wise, it certainly is. Is there, you had talked about the kind of integration with the exoskeleton or anything else that you can think of that AI and big data may benefit in your world?
Like I said, I think data collection will help drive or determine efficacy of treatments that we have.
Yeah.
And will determine what kind of care we deliver in the future.
Yeah, agreed. So You've taught a lot of medical students. You've taught a lot of residents, and you're even board certifying them in some ways. What advice do you give to those now that you get your chance to put your hands on and your thoughts into?
Tell them to keep reading, subscribe to journal articles, like New England Journal of Medicine, JAMA, and just get the subscription headlines. Always keep reading every specialty.
Yes.
So you're always informed about everything.
Yes.
And whatever piques your interest, then you dive in. You don't have to read everything.
Yeah. Well, I mean, you're a husband. You are now have this new job as of the last 4 months. You have 2 children that are young. How do you find your time to stay up to date on all the trials and this
It's the same way.
endless amounts of data that comes flying at us?
I kind of depend on headlines and articles that get sent to my email that I've subscribed to, and things that pique my interest, whether it's neurology, orthopedics, medicine. Then I start to dive in for the new articles.
Doesn't necessarily have to be PM&R related. You just kind of find whatever piques your curiosity and flow with that. Yeah, that's a great idea. So, all right, tell me what you do for fun.
Family time.
Yeah.
We go to the beach a lot these days.
Yes, you have a beach time. Different than the beaches in Fargo, North Dakota, as a matter of fact.
Just a little.
Slightly, yes. Okay. Well, so your wife gets to enjoy the warmer weather. Yeah, it's one thing that is just great around here in the Emerald Coast is that these beaches are world class. Really, really great. I had said for a long time that these are the best beaches in the world. Now, my wife and I went to Turks and Caicos for a honeymoon, and that's the second best beaches in the world is what I'll say right now. But it really is lovely to have that so close by, and you can go up and down all the way. If you ever get a chance to do the drive from here to Pensacola along the waterline, that's a really beautiful drive too. So I recommend that. Anything else you're doing for fun?
When it's winter, I like to snowboard. So.
It's not as much snowboarding around here.
But I can always travel.
Yes, you can. So good on you. One thing that I'm always interested in is kind of the scripts that we tell patients. So for example, I have a script whenever I'm going to consent a patient for a cardiac catheterization. It takes about 2.5 minutes. I've got it. And it's almost like I can check out at that time because my mind just starts to say the things and kind of. Do you have a script for things like rehab that you usually go through that your staff could almost quote for you?
So I don't do it that much these days because there's no implanters that I'm working with right now, but for baclofen pumps.
Yes.
Patients live with spasticity for a long time, and some of it's lifelong or it's been for many years after an injury. I would say, what would you do if I could take it away even for just an hour?
Yeah. I bet that would be a meaningful improvement in their lives.
Even if it was just temporary and just for an hour, what if I could take it away? Would you be up for it?
Yeah.
Yeah. And then, so I said, well, it's a lumbar puncture and it's a trial. It's an injection where we do fluoroscopy and then I'll inject the medication into you. And then within an hour to 4 hours, we'll see the response and we'll see if you're still as tight as you are or as limp as a noodle.
Yes. Yes. And I'm assuming you found a fair amount of success in doing this procedure. Is that right? Yeah. Yeah. And I mean, look, again, if you're in constant pain, an hour of relief has got to be great for these folks. So, yeah. All right. I'm going to go into some rapid fire questions here. Okay. And so I want to start off by saying, or asking you, who is the smartest person in history?
Thomas Edison.
It's not a bad answer there. Certainly had some insightful ways of doing a lot of different things. If we can live to 1,000, should we do it?
Only if we can physically sustain our activity.
And I agree with that sentiment. Not just decrepit 1,000, but correct. I mean able to continue to do the things that we want to do that provide meaning into our lives. How about at night? Do you want it too cold or too hot?
Warm.
Okay, that's the wrong answer. I'm sorry I have to tell you that, but it's too cold is the answer. If you could go back to when you started training in medical school, what is a piece of advice you would give yourself?
Break up with that girl.
Sage advice to yourself, okay? Well, turns out it worked out okay for you. So, What is one current medical treatment or therapy kind of in your world, or I guess in others, that you think we're going to shudder at in 15 years? Like, I can't believe we did that.
I mean, there's a utility for it, but I still, like phenol and alcohol injections or blocks for denaturing proteins and muscles for spasticity.
Yeah.
I mean, we still do it. There's an indication for it, especially in children, but it can cause pain and dysesthesias and not necessarily long-term benefits, so.
Yeah, I think we're probably going to get something better to utilize for
We've
that.
been using Botox for it. It's just that sometimes Botox doesn't last as long, so we'll combine the two to get better, longer efficacy for children.
Okay.
So it has utility, but maybe they'll come out with something better.
Well, I like this because it's not a modality that we're used to. I mean, you know, we think of using alcohol septal ablation for basically causing an MI and destroying myocardium. So this is an interesting way to kind of go about doing that. Alcohol in general is just going to mess some stuff up wherever it goes, and that's probably true in a lot of different ways. Finally, tell us what books you're reading right now. What books we should be reading.
I've been reading kids' books because my son has he's got this reading list, and he got a Scholastic magazine.
Yes.
So he's been reading this axolotl book.
Okay. Yes. Didn't know what axolotls were beforehand, but here we are.
That's what I'm learning.
Not enough vowels in that one, but
that one, and then Pain No More is another one that I've been reading.
What's that about?
It's a physician who's had a history of chronic pain and different modalities and different approaches on how to treat chronic pain.
Really? It almost hits a little too close to home, right, with what you're doing? But
it's good.
Good on you. Yeah, I don't read any cardiology books, I can tell you. I just stopped that. So maybe you could remind our viewers and our listeners where you're working right now and where they would find you in your practice.
Yeah, I'm over at Encompass Health, 1847 Florida Ave in Panama City.
Great. And we'll make sure to add that on here. We thank Encompass Health for being here. We thank you for being here into our community. Welcome. We look forward to having you take care of our patients and unfortunately some of us. But we're glad you're here. Thank you very much for being here today, Dr. Kenny Chantasi.
Thank you very much.
Thank you.
Pleasure to meet you.